Okay, so we're gonna pick it up again, and want to welcome and introduce Dr. Robert Louis, who's Chief of Neurosurgery at Hoag Hospital in Newport, Southern California. He is definitely one of the leaders in the space today, and it has helped get Hoag as a hospital to look at VR holistically throughout all the departments. So, Rob.
Thanks, Bob. Thanks, everybody, for having me, and it's a pleasure to be here. It's a little bit of a fire drill. I flew in from the UK yesterday, but I was planning on being here virtually, but it doesn't quite give the same message as being here in person, even though we are at a virtual conference. It's nice to be here in person and see everybody. I'm going to be speaking today about existing problems in my world, in the world of brain surgery, and how we use XR, virtual and augmented reality, to solve some of those problems. Just a little bit of a background. Neurosurgery is a relatively young field as compared to most of medicine. 1885 in the UK was the first recorded case in human history of successful removal of a brain tumor. Before any imaging, CT, MRI, they were able to, based on the symptoms alone, correctly localize the lesion to the patient's motor cortex. They even know it was in the mid portion of the motor cortex. They were able to, without anesthesia, without antiseptic technique, or without antibiotics, successfully intervene and remove the tumor from this patient's brain. Unfortunately, he died a month later from infection, but it was the first time in human history that we discovered we were able to successfully intervene on the human brain, and we thought with better perioperative care we'd be able to do it with long-lasting benefit. Fast forward, that didn't have a long-lasting benefit for the patient. So as physicians, our job is first do no harm, primum non nocere. This is a book by a British neurosurgeon who most of us, we think pretty highly of ourselves. A lot of big egos. This comes from a totally different perspective that it talks about how we all carry around a small graveyard inside us, and how, as a physician, to live through that and continue to be able to practice, even though sometimes we do harm. So as a self-aware physician trying to do less of that, we are trying to use technology to enable us to do surgery safer and less invasively over the course of time. Since that first operation, 130 years of technological advances have enabled us numerous tools, including things like endoscopy, where here in the center, those vessels on the surface of the optic chiasm are less than 1/10 of a millimeter. Nowhere else in the body does a vessel that size make a difference, but in this case, if you injure one of them, it leads to a black spot in the patient's vision. The big one at the bottom, they'll be missing half of their visual field. So using Ultra HD 4K endoscopy is one example of a technological advance that has enabled neurosurgery from 130 years ago until now to advance rapidly. However, as of 2019, there are still some significant problems in neurosurgery, including a patient with a tumor in the pituitary ending up with a deformity like this, having half their skull removed because of an infection. Still a problem 130 years later, because the operations were not done precisely enough, because the tools were not yet available, and now they are. So that leads us to problem statement number one, that there has never been a way to practice an operation on a specific patient prior to surgery. Chris Ahmad is an orthopedic surgeon for the New York Yankees. He wrote a book called Skill, where he compares the skills and training of elite athletes to those of elite surgeons. And he has numerous comparisons, Malcolm Gladwell's 10,000 hours, the mental preparation. However, when Michael Jordan became 6 times world champion, and I don't know how many times MVP, he still spent 5 days a week practicing basketball. Not games, practicing, shooting free throws by himself in the gym. In medicine, we call it the practice of medicine because we practice on human beings. Sometimes we do harm as a result of that. Prior to virtual reality, there was no way to practice a specific operation on a specific patient. So we used to just scroll through old school images like this and kind of think through in our mind what the operation was going to be like. Now, with virtual reality, I can simulate the operation. This was a patient of mine that was an artist that was losing vision in his right eye. He had this tumor in green, and based on the original images, I had planned an operation to go through his eyebrow, a minimally invasive craniotomy. When I simulated the operation in VR, however, I realized that this is most of the tumor, but that this tiny piece of tumor right here, I was not going to be able to see through the originally planned approach. Rather than making that mistake in a patient, I made it in the virtual model. I pressed reset. I said, let's make a plan B. Instead of going through the eyebrow, we went through the side of the hairline. Totally separate approach. From the side of the head, plan B gets us a whole view of the tumor to be able to remove the thing in one piece. Now, this patient, again, was an artist. Rather than making the mistake in a patient, I made it in the virtual reality model, was able to correct the plan and do the right operation for this particular patient. This is precision medicine enabled by XR. And it's been studied numerous times. This one was from Mount Sinai. When surgeons rehearse surgery for the specific patient using VR, as compared to traditional imaging, it leads to a change in the surgical plan nearly a quarter of the time. If you think about that a different way, almost 25% of the time, we would be doing the wrong operation for this particular patient had we not simulated prior in VR. Pretty powerful data. Problem statement number 2. Patients, if you think we don't understand these black and white images, patients do not understand medical imaging, period. I spend hours and hours trying to explain them to them. This, to most people, looks like a Rorschach blot. Well, I have to tell people that it's actually upside down and that the left side is on the right and that it's looking up at you from the feet. This is someone's brain. I'm often delivering the worst news that they've ever had in their life to them and their family. And now they're looking at this and they don't even understand what I'm trying to explain to them. When I show them this, that this is your brain, here's where the motor cortex are, here are the fibers that go to your speech pathway, this vein is critically important for the surgery. I cannot take away their condition, at least before we get in the operating room. But at that moment, I can take away the fear of the unknown. There's the fear of the condition and the fear of the unknown. We can open up the black box of surgery and show them what to expect, why there's a risk of this, why I have to be careful with this. And so they are now become empowered to make an informed decision. I call this enhanced informed consent or true informed consent. I tell patients that they are the CEO of their own medical corporation. I'm the CMO, give them the information, and COO, execute the plan. I have to give them all the information to make the correct decision, and I can only do that with immersive tools like virtual reality. When we study this, we study the effect it had on patients and how many of them left our system. I live within an hour's drive of UCLA, Cedars-Sinai, and USC, pretty prominent medical centers, well known for neurosurgery. Prior to using virtual reality for consultations, almost more than a third of my patients were leaving and going to those centers to have their surgery. After using immersive VR on a patient-specific basis, that number dropped to less than 5%. Meaning now, because they fully understand the surgical plan, I've taken away the fear of the unknown. I've empowered them to make a more educated, more well-informed decision. Almost closer to 100% of them actually stay at our hospital and have surgery with me. This is because of their increased level of understanding. You can see prior on blue, I was already doing a fairly good job of explaining to patients their planned brain surgery. However, after VR, 90% of patients rating their level of understanding as a 9 or 10 out of 10. Now, unless I'm operating only on other brain surgeons, it's unlikely that the average American who has a 9th grade health literacy level will get to that level of understanding in a 20-minute consultation using any other medium other than virtual reality. This is the power of this technology as far as educating patients. So we've simulated the operation so that I can get it right the first time on the real patient. And now we've helped them understand what the risks are. Let's hear from a patient.
On Monday, June 5th, 2017, I felt the worst headache in my life. It felt like an ice pick driving through my skull. A CAT scan revealed a bleed in the side of my head, the size of a softball. The only option to stop the bleed was to have a craniotomy to remove it. Being completely out of control is terrifying.
It's difficult to talk to patients about brain surgery because it's very abstract. We're combining delivering difficult news about a scary diagnosis with the additional fear of not knowing what to expect and not being able to understand what it is I'm explaining to them. When we show them the model, when they fly inside their own brain, they can see the structures, they can see the tumor, they can see the aneurysm.
This device creates an experience for the patient where nothing is unknown anymore. I'm not a doctor, so I couldn't understand what they were trying to tell me because I had never physically seen a craniotomy before. It's so hard to wrap your head around what they're about to do. When I put on the goggles, my surgeon asked me if I was ready to fly. In the moments where they were telling me really terrifying things, I also felt a little bit of peace from the way that it was being presented. I was able to, in real time, see inside my brain. I was physically there with them, looking at exactly what they were trying to communicate.
Before surgical theater, preparing for surgery was literally me sitting over a cup of coffee, kind of thinking, okay, I'm gonna do this, and then I remember that the optic nerve is here, but those preparations were a kind of ad lib. Now, with 360-degree 3D reconstructions, we're able to be inside that environment, which is as close to brain surgery as we can actually get without being there in the operating room. The advantage that the virtual planning and rehearsal brings to our readiness for surgery is the ability to simulate multiple different approaches. In a real patient, we don't get to try that more than once. We only get one shot at it. In the virtual model, we can do 2 plans, 3 plans, 5 plans, and see which one is the best for the individual patient. Make the bone look a little more like bone, so it's not translucent at first. Now that I can see the frontal sinus, I'm planning it, differently. Yeah.
Let's bring in the microscope.
When we're in the operating room and we get to the time of surgery, because we've done the preoperative rehearsal, it kind of feels like deja vu, like, okay, I've been here before, I know where the important structures are going to be.
Here we are, we're coming up to the back of the tumor right here. This would be a good place to do an overlay. Make the tumor more translucent.
I was at the hospital in the ICU for 10 days, and I had 2 angiograms, 2 MRIs, 2 CAT scans, and a craniotomy. I had a risk of having epileptic seizures for the rest of my life, not knowing that I'd ever be able to drive a car again, that I would ever be able to run again. But I would say the biggest testament to how everything went was the fact that I'm sitting here today. It was nothing short of a miracle. It made me more grateful for each and every moment that we have. We experience life in 3 dimension. Why should our medical care be any different?
If you didn't take away anything else from that video, the very last sentence of "we experience life in 3 dimension, why should our medical care be any different?" That's the whole message. To add the icing on the cake, Danielle just a couple months ago gave birth to a baby boy, and he's doing really well, both of them. So this is not just one patient's story. Now tens of thousands of patients across the United States and across the world have been able to benefit from this technology as champions like you guys, like the people in this room, are spreading the word that even sometimes now putting pressure on physicians. Listen, guys, catch up to the times. You're using 20-year-old technology. Stop it. Like we wouldn't let people fly planes without simulating first. We should not let people operate on our brains without simulating first. So that brings us to problem statement number 3, that traditional navigation requires the surgeon to divert their attention away from the operative field in order to find out where they are. This is a navigation system which has been around for 20 years. This is the way we do it. It uses an optical tracking system which uses an infrared fiducials that lets us find where we are in space. However, in order to figure it out, I have to stop what I'm doing, look at the X and Y model, look away from the microscope, look over there, reconstruct that X and Y model in my mind, and then go back to what I'm doing. Somebody earlier was talking about flow. It interrupts operative flow. It interrupts Michael Jordan from hitting 6 three-point shots in a row. We surgeons have the same thing. There are some days where you're in flow and it's a beautiful thing and the operation's just going. And every time you have to stop to look over and do something else, it interrupts that. It slows it down. It may take you out of that flow. You want your surgeon in the flow while they're operating. I use the analogy of maps. We all used to have to drive around. If we get lost, you stop what you're doing, you pull over, you find a map, you figure out where you need to go, and then you go back to driving. Now, every car in America is made with a navigation system, that can tell you there's an accident in 47 feet, there's going to be a 3.5-minute delay, and there's a radar trap. Slow down, you're going to get a speeding ticket. Right? This is in our cars that are $10,000, and yet in the operating room, most of the times, people are still using the equivalent of maps in order to find their way around because we neurosurgeons have big egos and are slow to adopt new technologies. However, now with tens of thousands of patients benefiting from this technology, the word is starting to spread. This is an example of how we use this augmented reality technology now in the operating room. On the left side of the screen is a microscope view 10 times magnified of a tumor on the optic nerve, so the nerve that gives you sight. You can maybe kind of see that the optic nerve is here, or maybe it's here. However, when I step on the foot pedal, I can see in augmented reality in the microscope through my heads-up display the tumor in green, left optic nerve, right optic nerve, and the internal carotid artery coursing through the shell of the tumor. The ability to see that within my field of view is the equivalent of a fighter pilot having all the targeting information in their helmet in order to be able to fly the mission, escape, from the enemies, and get the job done without missing a beat. That's the capabilities that augmented reality now delivers into our hands in the operating theater. This is an example of combining the two. So preoperative simulation using virtual reality combined with intraoperative augmented reality in order to make surgery safer and less invasive, and ultimately end up with better outcomes. A combination of technologies used, surgical theater powers the augmented and virtual reality ones. This is the patient with a vascular malformation in their occipital lobe. This is the lesion here. This is traditional imaging. Of course, this is the virtual reality simulation prior to surgery. The lesion being in purple. So this is our planned craniotomy or opening in the skull. The visual pathways are in green. So if I go too deep, even a millimeter here, the patient will have a missing wedge of their visual field. Knowing exactly where those are from simulating it, experiencing it before surgery, rather than scrolling through and guessing where it's going to be based on two-dimensional images. I do this until I know I can close my eyes and it's going to be right there. I do it until I get it exactly right for this patient. Then we go in the operating room. This is now in the operating room with the navigation probe, making sure it's tracking accurately. You'll see live microscope view on the left and intraoperative augmented reality view, which is a heads-up display on the right. This is now the hole in the skull that we made, that we planned in advance, and the overlay as I'm bringing in and out of the augmented reality of the visual fibers. As I open the door, you can start to see. So now, this is the vascular malformation here, augmented reality overlay here in purple, showing me exactly where the borders are. Again, the green visual pathway showing me exactly where not to go. If I go into those pathways, this patient will be blind on half of their world. Very accurately, within less than a millimeter, overlaying that in order to be able to see it and preserve it during surgery is kind of the holy grail of being able to perform surgery safely for patients. We remove the lesion and the visual pathways are preserved. In order to prove that to ourselves, we do an MRI with diffusion tensor imaging or tractography afterwards. So this is now post-operative. The planned craniotomy, we made a plan in VR and we executed a plan that was known to work in AR. I hate this idea of surgeons telling you, we'll see what we get. Well, when we get in there, we'll figure it out. That's not the way surgery will be. Every flight has a plan. If something happens, there's a plan B, there's a plan C, there's a plan D, there's a backup plan. That's how surgery should go in the modern era, and that is the capability that virtual reality and augmented reality afford us, the ability to make a plan and then execute a plan that's known to work safely in surgery. Initial studies, and those, of course, in medicine, we don't just do anything based on gut feeling. We study and publish the enhanced ability to visualize the lesion, to protect critical structures, and to accomplish the plan. This is in my hands using augmented reality for more than 200 skull-based pituitary cases now. Compared to rates in the literature, significant improvements in preservation of visual function, higher rates of gross total removal of tumor, and lower rates of readmission because of lower rates of complications, all enabled by the technological combination of VR and AR. Now more than 40 publications in this space in the healthcare world, extending anywhere from for preoperative planning and simulation for surgery, decreasing actual time spent in surgery, patient education, level of understanding, and intraoperative augmented reality for brain, and soon to be, within the next month, FDA cleared for spine surgery as well, in order to allow us to perform spine surgery more safely. Again, more than 40 publications and 50 presentations at peer-reviewed conferences. So this is how it goes. Before surgery, this is that same patient. You saw those black and white images now, a single image they presented with right-sided weakness and difficulty speaking, expressive aphasia. After surgery, within 3 days, a mild sensory deficit, the strength recovered, and the speech fully recovered, and afterwards showing preservation of function. This is one of the most difficult areas of the brain to operate in the dominant hemisphere near the speech and dominant motor pathways. But because of the ability to be so precise and predict where the critical structures are, it enhances, at least in my hands, my ability to do the operation more safely. There's this kind of theoretical thing that, we don't want to become dependent on technology. We should be able to do it, with a spoon. I said, listen, we are not in that era anymore. I don't want my surgeon to be not dependent on technology. I want them using every bit of technology they can to make the surgery safer and less invasive and more precisely planned for me. That's a theoretical fear, dependence on technology. My real fear in life is that I'm going to make a mistake that could have been prevented. And if there's a tool that you can give me as a surgeon that can make that less likely to happen, please put that in my hands for my patient's sake, if not for mine. So the summaries that advanced visualization technologies enable preoperative simulation to experience the specific case in this specific patient and allow the surgeon to make mistakes on the VR model safely rather than doing it on the patient, allowing the patients themselves enhanced ability to understand the surgical plan and finally presenting an accurate overlay for true heads-up display, real-time augmented reality to allow visualization of what I can see and also what I can't see. When CNN interviewed me about this, they said it gives us superpowers. It gives us the ability, surgeons, to see through things. This is augmented reality. In the end, all of this is great data, videos, it looks amazing. But in the end, if you ask yourself one question, if it were your loved one, if it were your family about to undergo surgery, what would you want? How would you want your surgeon to prepare? I know what I would want for mine. Thank you. I can take any questions you have.
So Rob, I'm actually going to start the questions off with a comment and a quick question. First, I think I've seen you present like 4 or 5 times now over a couple of years, and I think not traveling for 2 years has upped your game. I mean, you had a great presentation to begin with, but this took it to another level.
Thank you.
Honestly.
Thank you,
and
Bob.
so one of the questions
Practice.
is post-operative VR being used more, because actually that wasn't actually an aspect before in your presentation.
Yes, so yes, for the patients, for a couple of things. For the patient, they saw it before, now they see it after. So they went into this operation and they don't have to take my word for it that the tumor's gone or try to help them understand the DICOM images. They can see again now, be immersed, and they are relieved that the tumor is now gone from their brain. That's, of course, just showing them the postoperative models. The other thing that it affords us to do is, believe it or not, tumor board, the way we sit as surgeons together and review things is like kind of old school. I mean, literally, has the tumor grown? Well, let's measure an X and Y. X and Y don't give you the volume of a lobulated, uneven, it's a complex mathematical computation. The system can give voxel for voxel the exact, how much of the tumor I took out and how much is remaining. And the patient can see on a line graph, here it is, now 100% of the tumor is gone. So for helping patients to complete the cycle and then going forward from there, continuing to monitor them year after year as we get these MRIs, we can watch that over time and make sure the tumor is not coming back.
So I guess just to finish that then, on the, for keeping up with the patient and seeing if the growth has come back or not, is VR going to continue to be used for those annual checkups?
In my hands, yes, and I believe more and more as time goes by.
Hello.
Hi.
I was wondering what lightweight headsets doctors felt comfortable using, or what did they feel didn't get in the way versus did get in the way?
So the images you saw today from augmented reality are images that are injected into the surgical microscope. So it's actually, an operative microscope that we use. It's a heads-up display augmented reality that's projected into my oculars of the microscope. So it's not an HMD for AR and surgery. That's one way to do it. The second way we do it is if it's endoscopic surgery, I don't have a microscope. I'm working with a camera, and I'm seeing it on a screen so it's projected, it's overlaid on the screen. So far, during surgery, there aren't augmented reality devices that are FDA cleared for navigation during surgery using an HMD like Magic Leap or HoloLens yet. And I say yet because we have now, working with surgical theater, gotten response back from the FDA on this product for spine surgery. We've answered their questions. We're expecting before the end of the year that it will be FDA cleared, agnostic of the headset. So I've used it with both in the testing, in the trials and the studies. I've used both Magic Leap and ML1 and HoloLens 2. I think that there are advantages and disadvantages to both, although I don't think either of them so far is ideally suited for surgery. I'm definitely looking for an HMD that is more ideally suited for surgery. It's one of the things I'm looking for here.
Who built the technology to get into your microscope?
Surgical theater.
Okay.
The company's called Surgical Theater, yeah.
Okay.
And all of the VR, AR stuff that I showed is theirs. It was F-16 fighter pilots from the Israeli Air Force that designed the flight simulation technology that the Israeli Air Force uses to create their world to simulate flight. They came over and adopted it for use during brain surgery.
Where can I find your materials?
So surgicaltheater.com is their website there, but my website is brainspinemd.com.
Thank you.
Absolutely.
Hello.
Hi.
My name is Erica. I'm representing Memorial Sloan Cancer Center.
Hi.
This was an amazing presentation, first of all, and I had roughly 2 questions. Yes. One, what is the process and the patient journey from getting their brain scanned to creating the entire 3D model that had so much detail.
Yep.
I'm curious about that.
So some of it's automated and increasingly so. So it depends on the hospital system. We at Hoag have, initially we had a single cart where the patient would come in with their images. We have to pull them from packs and build it. And then the cart will be wheeled either to a patient's room or to the exam room. Because we had so much success in growing our surgical volume as a result of the increased conversion, the hospital continued to invest and double down on the technology. So now we have what's called a centralized enterprise model where at the hospital there's a virtual reality command center where techs sit all day long and build models off of the packs for cardiac surgery, for thoracic surgery, for spine surgery, for brain surgery, for any surgeons that are prostate, urologic, gynecologic oncology. So they're all being built. The average time to construct one for a single CT, if it's a CTA, it's automated. You just pick which tile. It's machine learning driven. Every time I make a case, the computer is watching me do it. So now we have auto segmentation, meaning AI segmentation of optic nerves, brainstem, ventricles. All of those are all done automatically. We're working on blood vessels next. For the most complicated one, like you saw there with 5 or 6 layers, pathways, tractography, vessels, it takes 15 minutes or so for the tech to build it, and then it's imported onto my desktop station, or it's available in any of the thin client PCs throughout the entire hospital.
Wow. And then my second question was, I saw the patient looking at her brain before surgery, it looked like.
Yes.
Does she do that like before surgery or throughout her process?
We do it before surgery all the time now. That's how I do my consults. This patient, this was like the story was made afterwards, because she's such a believer in the technology that she wanted to give back. But as part of the normal routine now, every one of my patients that comes into my office, they come in, they don't even see the black and white images at all. They see VR and the surgical plan. And sometimes I'll show them 2 or 3 plans and why I chose the specific one. Because they'll ask, why am I not going through the nose? And this is why, because the nerve's in the way.
That's awesome. Thank you so much.
Absolutely.
Yeah.
So just 2 minutes left.
Yeah.
So real quickly.
Sure, absolutely. I'll be quick. So Lance Bailey from healthysimulation.com, we're constantly reporting about the comparatives to the aviation simulation industry, but in that space they have CRM for crew resource management, communication protocols, they have black box technologies to figure out what went wrong, for learning, for systemic learning, and they also have trained simulation utilization, which is mandated and regulated.
Yes.
So in our space, as Brandon was alluding to earlier, we have to have champions that kind of push this technology forward. But that means we're on a technology adoption curve, and you and I are probably somewhere sitting in the innovator early adopter phase.
Yes.
Those folks that are on the laggard stage, the late majority, they're not going to do it unless they're told to.
Yes.
So you can certainly plead the fifth with me here, but my assumption is that we have to get to a place where our industry in healthcare is likewise mandated and regulated as it is in the aviation industry. And how do you feel about that? And what do you think that's going to take if you agree that, what will that take to make that happen?
I agree. I think the simplest answer is peer pressure from both fellow surgeons and from patients. When the patients they go to Cedars-Sinai and then they come back to me at Hoag, which is not as well known as Cedars-Sinai, but they didn't, wait a minute, you're showing me a black and white scrolling. I don't even understand this. I'm going back to the place where they have more advanced technology. So the market forces will drive it. This now it's, 5 years ago when I started working with them, they had probably done, 2,000 cases. Now over 100,000 patients have benefited from this technology across a wide array of specialties. So we're reaching a critical mass. I think, it's also a part of it. So peer pressure from patients, peer pressure from physicians. When I spoke last week or 2 weeks ago at Austin, and I've been speaking about this for 5 years, it was like small rooms, and this time there was 400 neurosurgeons sitting watching, and I planned to speak for 10 minutes and it went on for almost 45 minutes because people are the technology is there and the market is now ready, and so they're meeting at the exact right time. Actually, as we've talked about in many years in this space, COVID was actually perfectly timed, for all the bad of it, for the XR industry. It gave a little bit more incubator time to allow us to reach that critical inflection point.
Brilliant. Thank you for your help making this happen for the
Absolutely,
industry.
happy to.
This one's a quick one. I'm going to hire you to do my brain surgery. That's the first thing I say. But
You never want to need me.
more importantly, just 2 small questions. Medical students today are receiving this training, all of them, some of them, part of them?
Some of them in institutions, and increasingly so. Cadavers are harder to get, and they're infinitely dissectable in VR. There are some beautiful VR training systems that are available for medical students. I was a teacher of neuroanatomy for 7 years before I became a neurosurgeon. So that is an ideal use case, and I think it'll become in the next 5 years a standard part of medical school training. It's cheap, it's easy to do it again and again.
Second question, what's driving you to do all this? I'm just interested.
First, do no harm. Try to, anything each day that I can try to make my practice better, that I can try to have it less likely that I'll make a mistake. As a neurosurgeon, I mean, it's my real fear every day that I live, that like I didn't foresee something that I maybe could have, and that increased ability to make fewer mistakes is in the surgical VR space. Of course, is way beyond that. We could talk about it in another session, but in this space, it's truly that not wanting to hurt anybody.
You just want the world to know what you've learned.
Say that again.
You want the world to know what you've learned.
And more patients to benefit from it. Thank you.